morning, everyone. My name is Eric Yen. I'm the Director of Marketing for Shield Healthcare. Welcome to our webinar titled Living Well with Incontinence. Listeners will be in a listen-only mode. If you have a question, please type it on the chat box on your right-hand screen. Listeners will be eligible for 1 hour of contact hours through Capital Nursing Education. We'll tell you how to do that after the webinar finishes. At this time, I'd like to present Barbara E. West. She received her Master's of Nursing at Yale University in 1993 and her Wound Ostomy Continence certification from Emory University in 2011. Barbara has 12 years experience in hospice, and her experience in home health includes working with patients of all ages for both UC Davis Medical Center and Sutter. She has held several positions with Kaiser Permanente, most recently working in Sacramento at the General Surgery Outpatient Clinic and Vacaville Inpatient, performing full-scope wound and ostomy care. At this time, I'd like to pass the presentation over to Barbara. Barbara.
Thank you, Eric. Good morning, everybody. I've got a little bit of an echo here. Is that working okay for you guys? Let's see.
I hear a little bit of
quite a bit.
Do you want to turn your speakers off?
Is it any better now? Oh, I think we got it. Can you hear me okay?
Yep.
All right. Thank you, everybody, for joining us today. This presentation is called Living Well with Incontinence. And I was kind of surprised by the title. Shield picked the name, and as a continence nurse, my focus is generally on eliminating incontinence or reducing incontinence, and we will be talking about that today as well. But for a lot of people, incontinence is a fact of life, and this presentation is going to be about living well with incontinence. And I hope you appreciate the graphics that Shield did as much as I do. I think it's just gorgeous. Thank you. So we've got some big picture questions with incontinence, and it relates to discomfort. Incontinence is an uncomfortable condition. We've got safety issues. Incontinence can contribute to a fall risk. I don't know how many people fall on the way to the bathroom, rushing to the bathroom. The bathroom itself is one of the most dangerous places for falls in the home. And so we're going to be talking about that. And also incontinence devices like catheters, the tubing can present a trip hazard. Incontinence can also set you up for skin damage, and incontinence is often caused by an infection, and it can also lead to infection. On the social side, I think that's maybe the biggest part of it for a lot of people. We have issues of odor. Both urinary and fecal incontinence can lead to odors that are socially unacceptable. We also have noise as an issue. If you're incontinent of stool, you're probably also incontinent of gas, and you can't control noise coming out, and that can be a big deal socially. Also, incontinence products, being plastic backed, can make noise, and that can be embarrassing for people. Travel and bathroom access is a huge issue, because a lot of us can be continent if we have easy access to a toilet, but if you're traveling or going out somewhere, that can lead to incontinence because you don't have that ready access. Stigma is a huge issue, and we're going to be talking a lot about that. Think about how many jokes in elementary school were about incontinence. You know, somebody pooping their pants, wetting their pants. We just thought that was hilarious in elementary school. Independence. Incontinence can be one of the main reasons why people aren't able to live alone or need to be in a care facility. Psychological issues. Shame is a big factor for incontinence for people in our culture. A lot of it's going to have to do with your history of toilet training as a child. So even if this is 7 or 8 decades later, what happened to you during the period of toilet training is going to affect how you feel about incontinence now. Did you have a history of bedwetting? How did your parents and siblings respond to that? If you had very negative experiences at that time, it's going to come up now. And I have a friend who, her father recently passed away, but the last few months of his life he was bedbound. He was dealing with dementia to a certain degree. he was very resistant to perineal care and personal care, and he developed a horrible fungal rash. So they had to clean him more meticulously and apply creams, and it was like they were torturing him. And they just felt so awful, but they had to take care of their dad, but every time they tried to provide the care, it was so upsetting to him. So we're guessing there was probably something in his past, probably in his childhood, that led to intense shame around that part of his body. A lot of people experience guilt with incontinence. They feel guilty that other people have to help them or clean up after them. Frustration is a huge issue, both for the people that are incontinent and those that are helping care for them. Fear, and fear of incontinence can be almost as big a factor in your life as the incontinence itself, and we're going to talk about that. Isolation. Incontinence leads to isolation for so many Americans, and a lot of people just won't leave their house due to fear of incontinence. And then a lot of people won't let people visit them because they're self-conscious about the odor or noise. So isolation is a huge factor here. So speaking of coming out of isolation, I want to introduce you to Derek Fage. I did not know who he was until last year. He did a presentation for our Wound Ostomy Continence Nurses Society. And Derek Fage is a Montreal TV personality who went public with his personal story of living with lifelong fecal incontinence. He is now the ambassador and champion for the Canadian Continence Foundation. And talk about courage and coming out of isolation. Derek is an amazing illustration of that. So Derek was born with a congenital anomaly. I think it was a high imperforate anus. He basically had no rectal sphincter and had multiple surgeries as an infant and a young child to try to create an artificial sphincter. And these weren't 100% successful. And so he had to wear incontinence briefs up until the age of 13. And then even after that, he still was dealing with occasional incontinence. So you can imagine what it would be like going through elementary school, junior high, and high school, living with fecal incontinence. Derek was very bright, athletic, but socially he really struggled. He dealt with severe anxiety. And by the time he was in his late teens, he was suffering from depression and was to the point of contemplating suicide. And he got to a very dark point in his life, and then he just kind of realized, I can't keep hiding this. I've lived my entire life in fear of being found out, and I'm going to start telling people. So he started telling close friends. It was a huge breakthrough in dating women for him, because up until then, he'd been interested in dating, but anytime he got close to somebody, he would just run away for fear she would find out about his fecal incontinence. So he started talking about it, and his life really turned around. He got married to this beautiful woman. They have a couple kids, and Derek has an amazing sense of humor. He has a half-hour TED Talk, which I highly recommend, and the link to that is going to be at the end of our presentation today. But he says he would continually choose things that would be the last thing that somebody with incontinence should do, like doing live television. But that's what he did. He had his live morning show, Breakfast in Montreal. And about 5 years ago, a guest came on the show who was the head of the Canadian Continence Foundation. Derek had not arranged this. This was kind of a happenstance. And as they're chatting right before the show, he says to her, you know, by the way, I've lived with lifelong fecal incontinence. And she said, oh, really? That's great. And he was like, that's not the typical response I get when I tell people about incontinence. And she said, Derek, would you be willing to share this on the air? I think it would be a wonderful benefit to our membership. And so he said yes. I think it was kind of auspicious that he hadn't had a lot of time to think about it. So 5 or 10 minutes later, he is sharing on TV his lifelong struggle with fecal incontinence. And that is when his life really turned around. I'm actually getting chills just remembering him talking about it in this TED Talk. But he went on social media. He was already on TV about it. And at that point, he no longer had anything to hide from anybody. And the outpouring of support that he received from people dealing with incontinence, practitioners who help people with incontinence, it's just been phenomenal. So Derek is an amazing example of living well with incontinence and getting beyond the stigma, and he's helping us all to come out of that stigma. All right, we're going to be talking about different types of incontinence today. And I want to, from the very beginning, make two basic distinctions between cognitive and physical. So there are a lot of folks who are incontinent because of what's going on mentally in their head. Everything in their urinary tract and intestinal tract works absolutely fine, but either they can't remember what's going on or they can't process the signals from that part of their body. Perhaps they have dementia. And I think a lot of you listening to this presentation today may be dealing with folks with incontinence that has a cognitive base. And that's very different than physical incontinence. Someone like Derek Fage, who's got everything going on upstairs, he's aware of sensations, but he has a physical anomaly that makes it hard for him to control his bowels at times. So please keep in mind that those are two very different things. And when we're looking at treatment and managing incontinence, we have to really sort out, is this a cognitive problem or is it a physical problem? And then, of course, in a lot of cases, you have both. Okay, so looking at physical continence issues, we've got urinary incontinence, and that there are four main types. Urge or overactive bladder. That's where the bladder muscle itself is tending to spasm. The bladder is like a balloon. We're going to look at a diagram here in a few minutes. And the bladder is just contracting at times when it shouldn't. Stress incontinence is where the bladder muscle itself is okay, but we've got a problem with the sphincter, and that's the little muscle that closes off at the bottom, at the base of the bladder. And so when you cough or sneeze or jump on a trampoline, you're going to have some leakage of urine. Overflow incontinence is the most dangerous type of incontinence, and that's where we're having some problem releasing urine. It could be that the sphincter is too tight. With stress incontinence, the sphincter is not strong enough. With overflow incontinence, the sphincter may be too tight. It may be an enlarged prostate or some other reason why urine can't flow out. And what happens is the bladder fills up like a balloon. Eventually it starts to leak because the pressure builds so high. And what's dangerous about that is urine can start backing up in the tubes all the way up to the kidneys. And we'll look at that in a picture here in a few minutes. So if you have overflow incontinence, you need to get medical help right away. Functional incontinence is where things are basically working down there, but you just can't get to the bathroom in time. Maybe you're too far away from the bathroom, you're someplace where there's no toilet, or there's too long a line at a concert, or you're very weak, can't get out of bed perhaps. With fecal incontinence, it's a lot of the same parallels here. There could be a problem anatomically or with the nerves and muscles controlling the sphincters. Stool consistency is a very common cause for fecal incontinence because the sphincter, that muscle at the base of the rectum, it's much easier to hold in solid material than it is to hold in liquid material. So a lot of our work as continence nurses is working with patients to thicken the stool consistency, and someone can go from incontinent to continent just by thickening the stool consistency, having formed solid stool instead of liquid stool. And again, you can have functional incontinence with fecal as well. And then a lot of folks are incontinent of both bowel and bladder. Low volume versus high volume incontinence. I want to make a distinction here from the beginning as well, because they require different types of treatments, different products, and the very different life impact and cost. When you just tend to leak a small amount of urine or a small amount of stool, the social implications of that are very different than when you're getting flooded. Similarly, frequency. Some people are only incontinent a few times a year. Some people are incontinent, every few hours or even continuously. So that has a very different impact on your life. The same for predictability. Some folks may be only incontinent every month or two, but they can't predict it. So that fear of being incontinent can affect their life almost as if they had a much higher frequency of the incontinence, because the unpredictability is what's limiting them from being able to do normal activities. Risk factors for incontinence. Being older, chronic cough. This is where smoking is a risk factor for incontinence because of the cough that can be associated with smoking. Obesity and diabetes, these are separate risk factors. But with obesity, we have extra weight on the abdomen. That puts extra weight on our pelvic organs, the bowel and bladder, so it can make it harder to control the outlets. Diabetes affects the nerves in the pelvic area. So when the nerves aren't working as well, the sphincters aren't working as well. Pregnancy and childbirth is a risk for women. Again, we've got that extra abdominal weight putting pressure on the pelvic organs. Having had a hysterectomy makes a woman more at risk for incontinence. Prostate surgery is one of the biggest risk factors for men. And then we have neurological diseases like MS, paralysis. Medications can affect the muscles in the pelvic area, and they can also affect the volume of urine. So if you're taking a diuretic like Lasix and it makes you have to go pass a lot of urine every morning, you can be incontinent just because the sphincter is overwhelmed by the volume of urine that's being produced during a short time. Here's our diagram. This just shows the part of the urinary tract that's inside the pelvis and inside the abdomen. It doesn't show the parts that we can see where the base of the urethra connects to the penis in men or the labia in women. So the urinary tract starts with the kidneys that make the urine. They filter our blood. Then they send the urine down the tubes called ureters that connect to the bladder. And then there's the bladder like a balloon there. The urethra, the sphincters at the very bottom, and that controls passage of urine into the urethra. So this is where, if you're dealing with overflow incontinence, I want you to understand how important that is to get taken care of. Because when the bladder starts blowing up like a balloon, then we'll get urine backing up in those tubes, the ureters that lead to the kidneys. The kidneys can start to blow up like balloons as well. That's called hydronephrosis, and that can lead to kidney damage. So we do not want a bladder to be filling up to that dangerous degree. And I'll deal with this, folks after surgery. Sometimes the residual anesthesia medications have caused a problem with their sphincter. They go home from the hospital, but a day or two later, they're calling me, their bladder is full, and they have to drive into my clinic, and I'll put a catheter in. They feel so much better as soon as we get that bladder emptied. Then they just wear the catheter for a couple days until their muscles are back to normal and they're fine again. But it's very important that they call and come in right away. Anatomical differences between men and women. The basic issue in terms of continence is that men have a longer urethra. So that puts them at an advantage in terms of preventing leakage of urine. The urethra is like a long tube. Picture a long skinny tube that's made out of saran wrap and it's wet. So that tube tends to stick together. And so by men having a longer tube, they just have more of a barrier against leakage. So they're going to have less stress incontinence, but they're going to be at higher risk for retention. Some of that is from the longer urethra and also from the prostate. Men also have more options for external devices, as we'll see as we go through the slides here. In terms of risk factors, women are the ones who take most of the incontinence meds and have the most surgeries. They're the ones at risk for childbearing injuries and stress incontinence because of that shorter urethra. Men are more at risk, obviously, they're the ones with the prostate issues, and the post-prostate procedure incontinence is the most common form that men face. Men also have to deal with a correlation between incontinence and erectile dysfunction. And I just mentioned that here because many of the providers who can help you with incontinence can also help with erectile issues. It's something that we don't tend to talk about a lot in our culture, and a lot of men are hesitant to talk to their doctors about it. So I just urge you, if you're having an issue with erectile function, just like with incontinence, seek help. You know, we're going to be going over a lot of information today, but that does not replace getting one-on-one help from a trained provider. Incontinence has a lot of costs, and certainly financial. There can be a differential if we're using disposable or reusable products. Some people have insurance coverage for continence supplies. I know here in California we have Medi-Cal coverage, and so I think a lot of other states have Medicaid coverage, where people get a shipment every month for incontinence products. That could be absorbent products like briefs, or catheters, both indwelling and intermittent catheters. And insurance will often cover somebody to change the catheter. In the case of an indwelling catheter, you may have a home health nurse visit once a month, or you might go to a urology clinic. Another cost with incontinence is just the amount of laundry we often have to do, whether it's clothing or bedding, dealing with soiled furnishings and carpet. Sometimes items need to be replaced because we just can't get the odor out. And then the labor is very expensive too, whether you're doing it yourself or having to hire someone to do that kind of cleaning. There's also a big environmental cost. Adult diapers make up 7% of our nation's landfill waste. Infant diapers are about 2%. And so when I'm helping people with incontinence, I like to think I might be helping the environment as well. And it's one reason, even if we can't cure incontinence, if we can go from high volume to low volume, that's going to reduce the environmental impact. Different types of continence practitioners. Most people are aware of urologists. Those are physicians who can prescribe medicines and do surgeries. They don't tend to be as involved with the kind of holistic continence care that other practitioners are trained in. So it can be harder to find some of these alternative continence practitioners, and I really encourage you to seek them out, because the answers you might get at a urology office aren't necessarily covering the whole spectrum of incontinence treatment. We've got specialty trained nurses like me. A lot of us who are trained in continence are also wound and ostomy experts. So we have our WOCN Society, and we'll have a reference to that at the end of the slideshow. Don't overlook the nurses in a urology office. There can be a lot, they can be a wealth of information too. Just the RNs who are there working with the urologists have seen a lot. We have physical therapists and occupational therapists, and they're the ones doing a lot of the cutting edge continence work these days. They're the ones who work with biofeedback typically. And when you look online, they have some of the best websites and resources. Midwives are another source for continence care. Both home birth midwives and hospital-based midwives deal with a lot of continence issues and have great information. And midwives are doing more care, more postmenopausal care for women as well now. And I just want to mention pelvic pain specialists. Some people with incontinence also deal with pelvic pain, and there are a lot of people suffering from pelvic pain that don't have incontinence. But it's just something that is overlooked in my job. I just happen to come across a lot of people, men and women both, suffering with pain in the pelvic area. There is help available. There are specialists available. It can be hard to find. In my current hospital system, for a man to get pelvic pain care, he has to get a referral to the GYN gynecology department at one of our nearby hospitals. And so you can imagine the doctors have a hard time figuring out how to make those referrals. But if you're dealing with chronic pelvic pain, please seek help, and we'll have some resources at the end. So that's just my little pitch, because that message isn't getting out in society in general. Okay, urinary incontinence, precipitating factors. Infection is the #1 cause for sudden onset incontinence. So if you've been continent of urine and suddenly you're incontinent, you need to get screened for infection right away. Sometimes just a course of antibiotics, or getting the infection treated some other way, and you'll be back to being continent again. Intake, what you're drinking affects your output. So I'm going to drink to that here. I'm drinking plain water, because caffeine, artificial sweeteners, alcohol are all bladder irritants, and that can lead to incontinence. It triggers that spasms in the bladder. Retention is another precipitating factor that we've talked about. Prostate enlargement, folks after surgery having that where their sphincter muscle gets confused. I also want to talk about school teachers' bladder, and this is kind of close to home. I have a lot of women who have been school teachers in my family, most notably my grandma, and a lot of school teachers have trouble getting breaks to go to the bathroom. And so you'll see they have high rates of kidney stones because they try to not drink all day long. They're legally not allowed to leave the classroom with all those kids in it in a lot of cases. Some of them even have trouble getting to the bathroom on their lunch break. And so my grandma was one of them. She learned to hold it all day. And so by the time she was 60, she was starting to be incontinent. It turned out it was overflow incontinence because her bladder had gotten so stretched out, it was full of urinary stones. She happened to be in the Peace Corps in Africa at that time, but found a urologist in South Africa who was amazing, figured this all out, and he gave her a little glass tube. It was a catheter, and like she was never able to get one to replace it in the US, but it was just this short little tube, rounded on one end, and had little holes, pores in the side, and she would just stand in front of the toilet, and as she said, I would just pee like a man. And so for the next 35 years, she used that catheter to fully empty her bladder 3 or 4 times a day. She didn't have any more overflow incontinence, didn't have any infections, and it's amazing how this one little device allowed her to live a normal life for the next 35 years. But the moral of the story is, don't resist the urge to go. Don't chronically hold your urine. It can lead to all kinds of problems, as my grandma can testify. Urinary incontinence surgeries. I'm not going to go into detail here today, but there's a whole host of surgeries for women and men. I haven't had experience with men who've had these type of surgeries. It is more rare. It's just not something I've been exposed to. But I did spend a day in a urology office that was treating women. And I can just tell you, surgery is not the cure-all for incontinence. I know there's some people that get great results, but you can't count on it. So I encourage you to seek out other forms of treatment for incontinence before you consider surgery. And one of those forms of treatment is biofeedback. This is probably an occupational therapist or physical therapist. And traditionally, biofeedback was done in an office like this. Biofeedback helps you build muscle strength and coordination. You have to have intact cognition. So if you're dealing with dementia, biofeedback's not going to help you. And you've got to make a long-term commitment. You can't just show up for one session and expect to have your incontinence cured or reduced. I do think they are now starting to pilot biofeedback machines that you can use at home, which is interesting. But again, you cannot replace FaceTime with a continence practitioner. So even if they have home devices now, I would encourage you to seek help from a professional. So the way biofeedback works, it lets you see what's happening with your muscles in the pelvic floor, and it helps you see progress. Because if we go to the gym and we're working our biceps, we can, for one, we can see our bicep, and for two, if we can lift 10 pounds this week and we go to 15 or 20 pounds a month from now, we can see that progress. We can measure it. It's harder to measure progress with incontinence. And so a biofeedback practitioner has a small little electrode, just like you use when you get an EKG. It's just a little sticker they put on the perineum, and it can sense the action of the muscles inside the perineum. Because a lot of folks, when we start trying to build up our muscles in the pelvic floor, we might be contracting our buttocks, or we might be contracting our abdomen. We don't know how to isolate those muscles. A biofeedback practitioner can teach you that, and then once you learn how to work those muscles, you can learn how to make them stronger, and you can see the result. The little line on the graph there on the screen is going to go up higher when you do a really strong squeeze. So that gives you feedback, and that helps you progress. Because it can take a while to see progress with continence training, and so it helps to have that feedback in the moment, saying, yeah, I got up past the 80 line this time, and it helps you keep going and really achieve success. Exercise in general. We talked about specific exercises you do with a biofeedback practitioner. Kegel exercises are the generic name. You can look that up online. They also make vaginal weights or vaginal barbells. It's a small, a vaginal barbell is just a little stick that's got a ball on either end, different sizes, and you insert it in the vagina. You try to squeeze the muscles and then resist pulling it out and see how much muscle strength can you generate to grab onto that before you can pull it out. It's something you can do yourself. They also make weighted eggs. You can buy a whole set. They're not that expensive. You can get them on Amazon. They're like little eggs that fit up inside the vagina, and you start out with the lightest one, you insert it, and then you stand up and you see, does it fall out right away? Can I hold it in? Can I walk around the house and have it not fall out? If so, try the next heavier one, and then you'll quickly find where your limit is. And this is a way you can build up the muscles, and you're getting immediate feedback. General exercise also improves continence. My mom started an exercise program about a year ago. Nothing to do with incontinence in particular. It's just a regular physical therapist at a gym. But she has noticed her stress incontinence is dramatically reduced than it was a year ago. This, we think, is just because of building her core muscles, building her leg muscles, has also increased the strength of the pelvic floor. So her stress incontinence is dramatically improved from doing an exercise program not even related to continence care. She also has lost a little weight, especially weight off her abdomen, and so losing weight will also improve continence. Environmental modifications can also help you get to the bathroom in time. So, you know, if you can move your room closer to the toilet, that can increase your odds. If you're in a recliner chair in the living room and you have privacy in your home, you could put a bedside commode right there in the living room. Because if it's taking you too long to get to the bathroom, you might be able to make it to the bedside commode. Having a bell or baby monitor so you can summon help in time can help you be successful with continence, and just eliminating any barriers between you and the toilet. We're going to talk about clothing here in a minute. Having a urinal handy, it's particularly easier for men to use a urinal, but we'll have an example of a female urinal coming up here. Some men even have a urinal installed in their bathroom at home because if you're a little unsteady on your feet, having a urinal can make it easier to aim and get all the urine in the toilet rather than leaking or spraying. I just want to mention too, a bidet or washlet toilet seat. Folks with incontinence are often dealing with cleanup issues and having to rely on caregivers to help them clean up. But if you have a toilet seat attachment that has a spray to it, that can help you stay clean and avoid skin problems. And also a raised or lift toilet seat can make it easier to get on and off the toilet. Here's pictures of urinals. We've got the, on the left, the clear one is a typical male urinal that you might get at the hospital. And the penis can just go into that opening, so it's pretty easy to collect the urine that way. Female urinals you don't see as often. It takes more dexterity to use them, and it depends on the shape of the woman. But this red one here is designed to be pressed up against the female genitals, and you can trap the urine that way and collect it in the basin. And if you're careful, you can even someone who's bedbound can use this successfully without spilling. Take some practice. Again, modifications in the living room and bedroom. We've talked about some of this already. I want to mention, though, a Hoyer lift. Some folks could be continent of stool if they have a Hoyer lift. Maybe they're bedbound, but they only have a bowel movement every day or every other day, and they can predict when it's coming. It's not like sudden onset diarrhea. Having a Hoyer lift that can get you from the bed to the bedside commode could make you continent of stool. A Hoyer lift is a hydraulic lift. It attaches to a sling that goes under the person, and then you need somebody else to operate it. But it can raise you up in the air and swing you over to a bedside commode. And they make toilet slings, so it's cut away at the bottom so that you can sit on the commode without getting the sling soiled. Simplifying your clothing, you know, going from zippers and buttons to Velcro and elastic. And if you're using incontinence briefs, pull-up can make it easier to get them off in time to go to the bathroom versus tape-up. And a pull-up one, you can reuse it if you've managed to stay dry. So even though pull-ups are more expensive, they can end up being a cost savings for people depending on how you're using them. Toileting, we already talked a little bit about aiming issues and urinals, but having a different color for the seat can make aiming easier, or even a target inside the toilet bowl. These are different tips. Some of these apply for folks who are taking care of someone who has incontinence for cognitive reasons. Scheduled voiding or prompted voiding, just simply taking someone to the bathroom when you have the sense it's about time for them to go. A lot of folks, you know, if we take them to the bathroom, have them sit on the toilet every couple hours, they're going to be able to pass urine or stool successfully on the toilet. They're not going to be incontinent, or much less often. We can watch for signs of someone needing to go, getting agitated, you know, holding their crotch. Let's take them to the bathroom right then, and then we may avoid an incontinence episode. Limiting fluids in the evening can help with nighttime incontinence. And then making cleanup easier. Getting a wet, dry vacuum or carpet cleaner, putting incontinence pads on chairs, on the seat of the car, and again, finding a continence practitioner, because they can really talk through the things that relate to the details of your life to help you solve these problems. Urinary incontinence, we already talked about limiting bladder irritants, avoiding dehydration. This is important not just for preventing kidney stones, but because concentrated urine irritates the bladder. So a lot of folks think, oh, if I drink less, I'm going to be less incontinent. Not necessarily true. By drinking less, you become dehydrated, and then that irritating urine, even though it's a small amount, may trigger that bladder spasm. We've talked about exercise, and then there's some specific tricks in here that a continence practitioner can teach you, or you can look up online too. A lot of it, I was very fortunate to get to study with Dorothy Doherty at the Emory University program there, and she's the one who wrote the textbook on incontinence, or continence. It's called Incontinence, I guess. But she's just brilliant, and when she's talking about overactive bladder and bladder spasms, she'll just say, you need to tell your bladder who's boss, you know. So if you have that latchkey incontinence where right when you get home you're barely able to get through the door to get to that bathroom, she'll tell you, stop. Don't run to the bathroom. Stop right where you are. Sit down. Take a deep breath. Squeeze those pelvic floor muscles. Maybe do some of those quick flicks, and tell your bladder, we're going to wait. We're not just running to the bathroom because you tell us to. And you can train your bladder to respond to these cues differently. Here's an example of an external catheter for a man. It's a condom catheter. It rolls on the penis the same way that a condom does. And these can be great for someone where you can't really reduce the incontinence, but you can control it, especially for someone who's bedbound. Condom catheters can pose a risk to the skin on the penis, but I've seen a lot of men use these successfully for a long time. It does help if you have someone with some experience. So again, a continence practitioner, a lot of home caregivers or caregivers at institutions have really good experience with condom catheters. It can help you fit for the right size and the right type. Penile clamps or penile compression devices are something we don't see as often. I know they're kind of scary looking here in the pictures. These are only for men with stress incontinence who are cognitively intact, who have normal sensation and are aware of bladder filling and have the ability to open and close the device on their own. Because again, if one of these got left closed, you can imagine we could have a problem with urine backing up in the bladder up to the kidneys. These devices generally don't totally eliminate leakage, and they're best used just for short periods, such as going to an important meeting or strenuous activities, especially activities that might preclude bulky absorbent products like swimming or jogging. So these can be a good short-term solution, and you want to use caution, not use it for an excessively long time. Again, men have a lot more options here because of the shape of their genitalia. This is a male incontinence pouch. It could be worn under underwear or inside an incontinence brief. The penis fits in the pouch here, and so it's absorbing urine directly. So for low volume incontinence, this can make a really big difference. Finally, we have what they call a female external catheter. It's only one brand so far. It's a PureWick company. It was a woman physician, I think, came up with this because she was frustrated with how many women patients in the hospital are at risk for infection from internal catheters. It's something designed for folks that are bedbound because it does attach to this suction machine. The way it works is this blue and white part down at the bottom is like a sponge, and that is placed right up against the urethral meatus, right between the labia on a woman. The suction is on all the time, and when she passes urine, the urine goes into that sponge and is sucked down the tubing right away into that canister. I haven't actually seen one of these devices, but some of my colleagues at a nearby hospital have used it, and they say it's great. And it's a great way to eliminate an internal catheter, so you don't have the infection risk anymore for a woman. Intermittent catheterization is another way to reduce the risk of infection. And this diagram here shows that there's different levels of flexibility. My grandma had that little glass one that she got from the doctor in South Africa, so that was 100% stiff. But intermittent catheterization is a great option for people that can catheterize themselves, folks dealing with overflow incontinence like my grandma, people with spinal cord injuries. But if you're someone who deals with retention, you have to be very precise in your schedule so that you don't lead to urine backing up. And again, a continence practitioner is the best one to teach you the kind of frequency and technique. Here's an indwelling catheter or Foley catheter. This can be a good way to control incontinence for a lot of people, and it may be the only option for people that have serious retention. Risks are infection and odor. Sometimes the tubing and bags itself can develop odor. There are special ways to rinse with vinegar and water, but odor can be a problem, and different people's body chemistry can really affect that. Fecal incontinence, a lot of the risks here are similar to urinary incontinence. Loose stools or diarrhea is the #1 thing that's treatable that we're able to deal with. Let's see. I just want to say here, incontinence in general and fecal incontinence in particular is one of the most common reasons why family members are no longer able to provide care at home for a loved one. It's important not to feel guilty if that is a limitation for you. Some people are just overwhelmed by feelings of disgust. And some folks can provide care for incontinent folks and some folks can't. So I just want to put that out there because it's a reality. Different people just physiologically can respond differently to these kind of odors and visuals. When you're managing fecal incontinence, it's important to treat constipation and diarrhea. We'll talk about that more in a sec. Having a regular time of day to go to the bathroom can help. Normalizing stool texture, and we've got a detailed slide coming up on that. Anti-diarrheal medicines can sometimes help. You know, if you've tried basic dietary modifications, a low dose of Imodium could be the ticket to continence for you. It's important to protect the perianal skin, and different things that help us evacuate the bowel thoroughly, like having a lower toilet seat or raising up your feet, like the squatty potty is now, is a little footstool, so that you're more close to a squatting position. You may empty the bowel more fully, and that may help you be continent throughout the rest of the day. And bowel regimens are something that folks with paralysis use a lot, and that's where you use enemas or suppositories to have a full evacuation every day or two, and then you can be continent in between times. A colostomy can be a last resort option, especially for someone who's wheelchair bound or someone with a severe wound in the pelvic area. You know, certainly we don't like to go to surgery as an early option, but say you're someone who's independent in a wheelchair, but the one thing you can't manage is fecal incontinence. Having a pouch on your abdomen to manage the stool could be something you can manage yourself, and it could really make a big difference for somebody's life. So it is an option for some people. Constipation and diarrhea are the most common reversible causes for fecal incontinence. Constipation because by causing a blockage in the bowel, your body will start secreting liquid around it that can leak around it. And then if you have a blowout, the post-constipation diarrhea can last for days sometimes. Again, with diarrhea, increased frequency, volume, and unpredictability can lead to incontinence. To treat constipation, these are the typical recommendations, and I do want to mention I deal with a lot of calls after surgery. You know, people have been on narcotic pain medication, they're constipated, their stool softeners aren't working, so I spend a lot of time talking to people on the phone to get their bowels moving. And I'll tell them, if you could go walk a mile or two, that may help. And I had a lady just a couple weeks ago, she went out and walked 3 miles, and then she didn't even need to take the laxative. That was all she needed to do to get her bowels moving again. Treating diarrhea, the gold standard with diet is the BRAT diet: bananas, rice, applesauce, toast. And when I'm talking about rice and toast, I mean white rice and white toast, because the low residue diet, minimizing fiber, can often help resolve diarrhea. So I know most Americans are trying to increase their fiber, but in certain cases, Crohn's disease, colitis, and incontinence, reducing your fiber may help you thicken up the stool consistency. What are your triggers? For some people, caffeine. Some people, it's dairy. Keeping a food diary and a diary of your stool pattern can help you figure it out. Some people swear by certain things. Pectin, you can get pectin supplements. Marshmallows, I've had some people say a marshmallow a day is what was able to improve their stool consistency. Peanut butter. If you look at the ostomy food list, because ostomy patients are people that are wearing a pouch on their abdomen where the stool empties, if they're having liquid stool, it's a lot harder to keep a pouch seal. So the ostomy resource people and literature have a lot of information about how to go from liquid to solid stool or more formed stool. So that's a great resource for anybody who's dealing with fecal incontinence. Conservative therapy, very similar to urinary incontinence. Biofeedback can also be used here. This is a fecal pad. A lot of folks don't know about this. So it's specifically designed for low volume fecal incontinence. You just fold it in half. It fits right up between the buttocks, right up against the anus, and easy to change in a public bathroom. You can carry extra supplies in your pocket or your purse. An anal plug prevents uncontrolled loss of solid stool for some people. It's not a solution for everybody. You insert it similar to a suppository. It expands like a tampon into this mushroom or cup shape. It prevents odor because it's retaining the stool inside the body. And some people can use it up to 12 hours. A lot of people have discomfort with it, and you have to have a certain amount of manual dexterity and cognitive capacity to be able to use it, but it is an option. A fecal collector for someone who's bedbound. This is similar to an ostomy pouch, but it can be applied to the rectum directly. Medical treatments. I do want to mention bulking agents. We use fiber to prevent constipation, and I talked about reducing fiber in your diet to try to thicken up the stool. But sometimes the right amount of fiber can act like a sponge and help stool to be more formed and less liquid. It's kind of tricky to work with this. You sometimes have to use really high doses, and again, a continence provider, maybe your best guidance, or some of these websites could guide you as how to use something like Metamucil, a fiber agent, to actually thicken stool. And anti-motility meds, suppositories, or enemas can be used as part of a bowel program. There's surgeries for fecal incontinence, similar to urinary incontinence surgeries. General absorptive products. A lot of you all might be Shield customers. That's one of the services that Shield provides. You've got pads for the bed, for chairs, briefs, tape up, pull up, and then underpads coming up on the next slide. I just wanted to mention this because this wasn't something I was aware of until I was doing research on the Shield website, actually. These washable underpants, I'll just read you the blurb because it's not something I've had experience with, but it just seemed like a great idea, especially when we're looking at environmental costs and financial costs. These are super soft cotton and polyester fabric. They're comfortable with the same look and feel of traditional underwear, but they also include a waterproof panel at the bottom in order to securely add a pad or a liner for a double layer of leakage protection. They can be washed and reused, so they can use, both men and women can use them. Sometimes it's hard for men to have to adapt. Women are used to having to wear menstrual pads at some point in their life. Some of the same products can work for men, especially with fecal incontinence, but there are special guards for men that are anatomically shaped for men. These are underpads or mattress covers. There's the disposable kind, but there are also washable kinds, and I was surprised how inexpensive. Some of them are just $3 or $6 for a reusable pad, and that cost savings can really add up over time if you've got laundry facilities right there. For higher volume incontinence, there are diaper liners or these booster pads. They don't have plastic backing because they're designed to be used inside a larger absorbent product like a brief. And then also on the left-hand side, these belted shields are for someone who's kind of in between. You need something more than a pad, but you don't need a full brief. So there's a lot that's out there, and I think Shield has folks available to talk you through some of the products they offer. Different kinds of cleansers. There are disposable wipes that you moisten with tap water. Some come pre-moistened. Some have different lotions and skin protectants in them. And you can also just, go to Walmart or Costco, buy a big pack of washcloths and use those. So it just depends on what works for your situation. Lots of different kinds of skin protectants. A lot of them contain zinc, which provides a barrier to protect your skin from urine or stool, but also helps to heal the skin if it has been damaged. There's a special product called Marathon. It's actually super glue or cyanoacrylate. There's only one medical brand that's available right now that I'm aware of, and it's not something we typically use for incontinence care, but I'm just mentioning it again because if you have someone who's lost their skin due to something very caustic like drainage from a stomach tube or something, it's like super glue making a waterproof raincoat on the skin. You got to be careful using it that you don't glue yourself together or glue yourself to your bed, but I just want to mention it because a lot of folks aren't aware of it. So we're coming to the end here. Here's some internet resources for continence-specific things. This Pelvic Guru website, you'll find some great referrals there. There's a lot about pelvic pain there and a really good sense of humor. Here's Derek Fage again, our spokesmodel for incontinence, as he calls himself. And again, back to the title of this presentation, Living Well with Incontinence. I don't think you have a better example than that. So here is the link to Derek's TED Talk. It's just a half an hour. It's amazing what he fits in his life story there. And I'm kind of choking up just thinking about Derek and remembering listening to that TED Talk from a couple weeks ago. There's a longer talk that he gave to the Wound Care Ostomy Continence Nurses Society if you want more details about some of the emotional agony he went through as a child growing up. And then some general resources, because if you're dealing with incontinence, you might be dealing with other care issues as well. So, and here's some of the books I was using. Again, just some general caregiving books, because when you're dealing with caring for someone with incontinence, there's probably many other issues throughout the day, and it's important to know that you're not the first person who's been trying to solve these problems. So I think we're ready for questions. I really appreciate you joining us today, and I appreciate SHIELD coming up with this topic, living well with incontinence. It's not a topic I would have thought of, and it's really helped me to think about it over these last couple months, so thank you.
Great, thank you, Barbara. That's a wonderful presentation. If you have a question for Barbara, please type it on the chat box to the right-hand side of your screen. While we wait for questions, there were a bunch of questions regarding the presentation. So the recording will be posted on the SHIELD community site. So that's shieldhealthcare.com/community. So it will be posted this afternoon. You can also download the PDFs as well if you missed any portion of it. We've got a couple of questions here. Barbara, you talked about infection. How does one screen for infection?
So in most cases, that's a simple urinalysis test that a doctor or a nurse practitioner or midwife would order. You pee in a cup, or if you have a catheter, you take a sample from a catheter sometimes. But you basically pee in a cup. The doctor sends it to the lab, and they're within an hour or two, just by looking at the urine under a microscope, a lab can rule out whether you're likely to have an infection or not. A lot of doctors nowadays will order culture and sensitivities, where they actually put some of the urine in petri dishes and see what bacteria grow out and what antibiotics will be the most effective. And that's the best way to treat a bladder infection or a urinary tract infection, because then you're taking the antibiotic that is specific to whatever organism is growing there.
Great, thank you, Barbara. There's a question here on how to receive your CE credits. So if you see the handouts on the right-hand side of your screen, you can download those handouts. Look for an email from Capital Nursing Education and follow those steps in order to receive your 1 hour contact hour through Capital Nursing. If you are watching as a group, you would have to sign the individual's names on that list. But the easiest way is to download those handouts on the right-hand side of your screen, or wait for the email from Capital Nursing. Question here for you, Barbara. Can we use FlexiSeal stool collection device at home?
I don't know the answer to that. I imagine you could. I don't know if you need a prescription. I've only ever encountered it in a hospital situation. But you know, having done both home health and hospital care, I know there's a lot of you providing care at home that are beyond the expertise of a lot of our folks in the hospital, because you know the person you're caring for so well. I think a lot of the home caregivers I know would do well with managing that, but I don't know about the availability. You know, there's a risk for damage to the anal mucosa with a Flexi Seal. There's several different risks that can be involved, but I imagine that folks at home could learn that risk just as well. I mean, certainly we don't use them perfectly all the time in the hospitals either. So I just haven't seen it. I haven't seen it used at home, so I don't know if it's possible or not, but it seems like it should be. But you would have to be really willing to take that on, you know. And again, if you're looking at needing a Flexi Seal at home, what's going on? Are we dealing with chronic C. diff infection that we can treat? Are we dealing with a stool consistency problem? A lot of times I see overwhelming diarrhea in response to tube feedings. I see that people are either on the wrong tube feeding formula, the wrong kind of supplement, or it may be a person whose intestinal tract is shutting down and they just can't handle that much calories. A lot of times we're trying to maintain weight on people who don't have the metabolic capacity to keep that weight on. So if you're dealing with loose stool to that extent over that long a time, I would encourage you to look at what can you do from a stool consistency side. And you know, there's products like a banana troll, banana flakes that go in tube feedings. There's all kinds of ways to address stool consistency. So if you could address that, it would be superior than to going to a Flexi Seal.
Great, thank you, Barbara. There's a great question here. For folks who are living with dementia and can't retain info on incontinence and or having behavioral issues, any tips you can share on working with those individuals?
Right, so that's where we as the caregiver have to educate ourselves. Educating the person with dementia isn't going to pay off, and getting mad at them and frustrated at them isn't going to help either. So that's where, still as a care provider, it may be worth it for you to go and meet with a continence provider, a continence practitioner. But that's where we're looking at environmental modifications, clothing modifications, dietary modifications. You know, are we giving liquids throughout the day? Are we reducing liquids at night? The prompted voiding, scheduled voiding. There are a lot of things we can do as a caregiver to minimize incontinence. But it can be very, very challenging, especially for folks with dementia, like my friend's dad, who has issues of shame, gets combative when we're trying to provide care to that part of the body. So I encourage you to reach out to support groups, talk to other people who've had success with a similar situation and learn their tricks. There's a lot of online resources. So there's a lot you as a caregiver can do to change the environment, change the daily routine, change the intake that can make life easier. And then talking to folks that specialize in incontinence products, like folks at Shield, maybe there's a more absorbent product you can use, or one that, because I'm just imagining from the question, you may have somebody who's tearing off their incontinence products, you know, at home, getting combative like that. Those are really hard situations to deal with, and sometimes we're having to deal with primary care doctors, medications to help people cooperate better, or changing medications to affect bladder control, urinary output, mood. Depression and anxiety can make incontinence a lot harder to deal with. So sometimes dealing with the psychological aspect is going to make your incontinence situation more solvable.
Great, thank you, Barbara. I think we have time for one more question, as it's 10 o'clock right now. So how do you diagnose for overflow incontinence?
All right, good question. Sometimes it's obvious, just looking at the abdomen. You can see someone looks like they're about 5 or 6 months pregnant. That's how big their bladder got. A lot of nurses like me are trained. When we have someone lying on an exam table, we can kind of look at the abdominal contour. It's harder when someone's very obese. You can't always tell. A lot of it is by history, but this is where you need a physician, a nurse, some kind of continence provider to assess it. We now use bladder scans, which is an ultrasound machine that you have a wand with jelly, and you swipe it across the abdomen, and it can measure the volume that's in the bladder. So that's a pretty good way to know that. Those are pretty reliable. We have them in hospitals and doctors' offices now. The way to know for sure is you put a catheter in somebody and see what comes out. So someone says it's called a post-void residual. They go to the bathroom, they empty as much as you can, they come back into my office, I put a catheter in them, and if I get a liter of urine out, then I know we're dealing with overflow incontinence. So a catheterization would be definitive to see how much urine is left in there after they've done their best to empty their bladder themselves.
Great, thank you, Barbara. That concludes our webinar for today. I'd like to thank Barbara West for that wonderful presentation. Thank you so much. I'd like to thank everybody who attended the webinar. Again, if you missed any portion of this webinar, it is recorded and will be posted on the SHIELD community site. That's www.shieldhealthcare.com/community. Again, thank you very much for attending, and we'll look forward to seeing you next month on our next webinar. Thank you, everybody.
Thank you.